More and more, I think, patients will come to their family physician with a complaint, maybe it's some numbness, some tingling, etc. And educating that community of physicians to be able to look for, somebody who comes to them with these complaints in the right demographic, maybe, a young woman or, postpartum or something like that, and they have these complaints. I'm seeing more and more physicians taking an active role in referring them to a neurologist to get an assessment. And those neurologists will work it up, and if they feel it's MS and appropriately so, they'll go ahead and initiate therapy. But I do think that the practitioner can help be that person who thinks about, is this MS, and makes the appropriate referral. And in some cases, some of the primary care physicians are pretty good about making the recommendation for the patient to get an MRI scan because they believe this could be MS. So I think it's out there at a greater degree, but maybe not at the degree we believe it should be, because we still unfortunately see the cases of people not being thought of seriously about their complaints, particularly for young women who might have recurrent episodes of numbness in their hands or their feet or their face or whatever, and they just say, oh, it's probably stress. But I think more and more physicians are starting to think twice about, maybe this could be MS. I think that one of the challenges that we have as MS specialists is to adequately train and adequately educate all the general physicians out there. And so we have lots of patients who come from rural areas of Pennsylvania or, maybe even West Virginia or Maryland or, New Jersey. And we go out there to try and educate them with, grand rounds programs, things like that to really give them a better understanding. Now, that being said, in far remote areas, it can be a little bit challenging for patients to would have to drive many, many hours to get to a specialized MS center. But I think that because we have such good long-term safety data with the original medications that are available, maybe it's not the long-term data for the newer drugs, but for the other drugs, they can start patients on those drugs and they still work. And if they feel comfortable with the idea of doing that, that's fine, because it's better than not doing anything. And if the patient then fails and needs to get more specialized assessments, making that referral to go into the MS centers might be appropriate. And the world of medicine is trying to move into the telemedicine conversation, and there are a number of places that have set up remote type of assessment sites to be able to do that. We are looking at and piloting in certain disease phenotype areas like Parkinson's disease, where patients may not be able to get in. We haven't yet piloted it in MS, but we are hoping to do that. Yeah, so we still have plenty of people out there who are living their understanding of MS and their therapeutic interventions from 20 years ago. And they may not have been keeping up on what's going on in the field. And so we'll get patients who eventually make it to us and say, my doctor, had made this recommendation. He never gets MRI scans. He never does this. He never does that. And what we try and do in that setting is maybe pick up the phone, call the physician, let them know what the current state of affairs are with some of this. We'll send our reports and letters back to do that as well. But in a way that I think is appropriate for educational, not for saying, you're not doing a good job. But, I think that's one of our roles, in addition to taking care of the patients, but be able to educate the community about where the state of the field is in MS and what the therapeutic agents available.